Well, good morning. I am going to, it is 7 o'clock, and I'm going to go ahead and get started so we can get you guys going on your day. Thank you so much for joining me this morning, bright and early. My name is MelissaTaggart. I am a GI pathologist at MD Anderson Cancer Center, and I want to talk to you today about biomarkers in colorectal cancer. But first, we're going to hear from one of our ASCP patient champions about her journey with colon cancer. So hopefully this works. Let's see. Here we go. Maybe it didn't. Give me 1 second. Let's start this again.
Move this over to the side.
Okay.
And then when you need to go back.
My name is Rebecca Toby. I am a colon cancer survivor. In July 2009, I finally had a colonoscopy for mysterious stomach pains. After having had multiple tests, the doctor walked in and said, "You have colon cancer, you should have seen a doctor yesterday." I was absolutely stunned. I was very frightened. You never know what the outcome is going to be. During that period of time also, my sister, who was a GI pathologist, she was able to take my lab specimens and send them off to one of the top colon cancer doctors in the country. So he was able to confer with my doctors and decide that the treatment protocol that they had designed was correct. They were able to do my radiation treatments here in Santa Fe, so I did those every day, and I also took a chemotherapy drug at the same time to augment the radiation treatments. And then once a week, I went to Albuquerque for chemotherapy. Every time that I went in for treatment, I had a blood draw, and the lab would check my levels to make sure that I was strong enough to have the chemotherapy at the time. There was a wonderful lab team behind the tests, and by the time you see your doctor, they have the results. I'm a person that has not a glass half empty or half full. I'm a person with an overflowing glass. And I am so grateful every single day that I went on this journey and that I can appreciate life in a way that I never did before. I would go to Albuquerque. I had a different friend every time drive me down to Albuquerque for my infusions. They lasted about 5 hours. I did get terrible radiation burns from the radiation treatments. Colon cancer is a nightmare. The treatment was very, very difficult. I finished my treatment at the end of September, early October of 2009, and they told me that I would have to wait a period of about 10 weeks so that everything would calm down, and then at that point they would do another PET scan to see what the status was. I went in for the PET scan and the tumor was gone. It was the most wonderful, rejoiceful day. I'll never forget driving away from the hospital. There was a particular song that came on the radio that was about happiness, and I was just singing at the top of my lungs. Without lab professionals and pathologists, I think that modern medicine would be in a world of hurt these days. Lab professionals and pathologists help doctors make accurate diagnoses, and where would we be without that?
There's one simple hearing hack anyone can use to improve their hearing almost overnight. Did you know that hearing impairments have nothing to do with your ears? The ears are nothing more than a microphone to the part of the brain.
Try and close that window. Well, that was unexpected. Okay, let's move on to talking about biomarker testing, which is really important in making decisions about every cancer nowadays, and especially colorectal cancer. So, my disclosure, I don't have any financial relationships to disclose. Why do we need to talk about biomarker testing? Well, I don't really have to tell you this, and this kind of just compounds on the story we just heard is, for the most part, we're trying to choose the correct chemotherapy or the correct treatment for the patient, for that particular patient's disease. So we really want to do the best that we can and find every marker that we can so that we get them on the right track so they can have the best outcome with the least amount of comorbidities. So as you can see, just even from in the past 10 years, the amount of biomarker testing has increased, and it is projected to keep increasing. This is not something that is going to stay stagnant, and we're going to have to keep continually learning about all of the different biomarkers in each particular tumor type. Now, I am not a molecular pathologist, so I will not be able to give you details on a lot of the intricacies of testing. I am just a surgical pathologist, but I have the luxury that I am subspecialized in colorectal, in GI cancers, and I spend a lot of time with our colorectal surgeons and oncologists. So it's great that I get this team to interact with, and they teach me a lot every day. So just remember, too, that there are exceptions to every rule. There are exceptions to even every test, and that knowledge is always evolving. So the topics we'll talk on today are, of course, biomarker testing principles. You have to have some principles behind it. What are the current recommendations for approved therapies? We need to know what the clinicians are how they're treating, what the guidelines are being told to them so that we can help them make choices in testing. We'll go through the major biomarkers in colorectal cancer. We're going to spend a lot of time on DNA mismatch repair proteins because I think that is one of the testing areas that surgical pathologists spend a lot of time in. Some of the other ones may be, the choice of the test may be controlled by the clinician, but you do have to know the background of those tests and actually what they need to be testing for. We'll touch a little bit on some other prognostic tests that that the clinicians can use that we may just be tasked with choosing a block for, and then some future directions. So why do we do this? What do we test? When do we test it? How do we test it? Why? Well, we've talked a little bit about that. Predictive. We want to look for predictive on how likely the patient is going to benefit from this particular treatment. That goes into tumor profiling. We want to steer them into the most personalized treatment for them. And it also gives them opportunity to clinical trials if they're unlucky enough to fail most of the treatments. So hopefully getting them into a good clinical trial may be a lifesaver for them. It's prognostic. Gives us some prognostic information, so that just means in the untreated individual, how likely are they going to, how aggressive is this disease going to be? We do get some information about inherited genetic alterations, even in some of the immunohistochemical stains that we do, and it makes a big impact on not only the patient and their family. It helps with primary site determination and confirmation, and we're starting to see this more and more as people live. Luckily, and it's fantastic that we're turning cancer into almost a chronic disease, but we do then sometimes get recurrences that don't look like the primary tumor, and that has helped a lot using a molecular confirmation. And then on the science side, molecular classifications are starting to come up. Occasionally, those have histologic correlates, so we can look at the histology and maybe say, you know what, I think this is going to have this molecular abnormality. So that always helps us. And pathogenesis, of course, we want to know correlation with precursors, risk factors, and especially in colorectal cancer right now, where a lot of our new patients are under 50 years old, what's going on that's actually causing that. So what do we test? Primary versus metastasis, treated versus not treated. It really depends on the test, really depends on the patient, depends on how much they've been treated. Just know that in a patient who has maybe had one round of therapy or no rounds of therapy, the primary and the metastasis have a really high rate of concordance. So whatever you have, you can use. In the patient who's been through 4 different lines of chemotherapy, though, you might want to get a new biopsy and test that metastasis, because there will be selection of clones by the prior treatments. I like to say, whatever I have that gives us the most tumor, that's going to be adequate and gives me the fastest turnaround time is probably the best thing for the patient that time, unless they've been treated by numerous rounds of or lines of chemotherapy. We certainly can use formalin-fixed paraffin-embedded tissue. We can get a lot of information from that, including RNA, and we'll talk a little bit about that in just a minute. Cytologic specimens are also really great for testing, may require some additional validation. And then now the clinicians are turning to plasma and actually looking for circulating cell-free DNA. When do we test? And that seems to be a question for a lot of people. The clinicians, I hear a lot of people, and it is different for each institution, and it's something you might have to have a conversation with your clinicians. We require our clinicians to order everything, so we do not reflex anything except DNA mismatch repair proteins on colorectal cancer. So they have to order everything. It can be tumor dependent, it can be site dependent. We'll talk a little more specifically about colorectal cancer. But it could be at the primary diagnosis, at recurrence or metastasis, or at that time of therapy failure. We may be repeating a lot of the tests at the time of therapy failure because of clone selection. The treatment selection for prediction, the clinicians usually do go under current indications by major national groups. We can do it on clinical request, because the physicians can use things off-label also. And then for risk stratification, that might be something very important to that particular clinician to know in advance or earlier than we normally would test. And then sometimes you need it for particular situations like a clinical trial or concern for a hereditary condition. Patients 40 years old, and we can do a simple test for the DNA mismatch repair proteins. We don't have to, they will still probably go to a genetic counselor, but we can give them a lot of information before they get there. So how do we test? Well, it is the era of next generation sequencing, and we've really been lucky that we have a lot of these big panels that incorporate a lot of different testing. So when I first started this, we were testing individual genes. And this has been fantastic. We get so much information now. You can test for multiple anomalies. You can compare it to normal. You can even pick up sometimes germline abnormalities. So we're getting away from this kind of hotspot evaluation, the Sanger sequencing, the pyro sequencing. There was talk a couple of years ago of the next or the third generation sequencing. I haven't seen that come yet, but I'm sure it's in the works. And then some of these other specialty ones, whole exome, whole genome, really are kind of in very, very special situations. And then we have the circulating tumor DNA, the liquid biopsy, which the clinicians are using more and more, but we really don't have a lot of guidelines on it. So for RNA analysis, we can also use next-generation sequencing. It works pretty well. It will depend on the platform that you have. We also can use in situ hybridization. And then for research, there's this whole new realm of transcriptomics, where they can look at multiplex panels of what the tumor is expressing, and it's giving us a lot of insight. For protein expression, we can certainly look for surrogate markers for amplifications or specific mutations, like, say, retinoblastoma mutations, fusion overexpression. They have track, like NTRK markers, aberrant expression, and we can use the immunohistochemical stains. And again, for research, there's this whole multiplex panels for proteomics. And then in situ hybridization, we can look for amplifications and fusions, and there's a number of different ways. So when you're selecting for NGS, you want to consider a lot of the pre-analytic factors: cholischemic time, paraffin block age, decalcification. Paraffin block age is really kind of coming to the forefront. We certainly don't want to use a paraffin block that's going to give us false negatives, so we really want to make sure we get the mutations that are there. So I think for DNA it's like 5 years, so it's quite a while, but for RNA that degrades a lot faster, so maybe 2 years. We want to choose the most representative block, and we want to try and avoid areas of necrosis, inflammation, mucin, fibrosis, if possible. I certainly do, when we have a very mucinous tumor, use a lot of mucin, but just remember that the cellularity is, for that particular area, is going to be lower. If you have multiple samples available, try to go for the most recent sample. If it's adequate, though, we try and test the metastasis, but if I have a small cluster just in a sea of necrosis on a liver biopsy, I'm going to go back to the main tumor and get the more adequate sample. And then we have to include the percentage of tumor. Just remember, you have to subtract out any normal nuclei. So inflammation puts in a lot of normal nuclei. So when you have things that have intratumoral lymphocytes, you're going to have to subtract them out, and your cellularity goes down pretty quickly. So we'll talk a little bit about evolving principles. For personalized medicine, we're actually getting to the point now where even if the patient has an uncommon mutation, so say like an EGFR mutation in colorectal cancer, which is really rare, there may be a drug that's being used for EGFR mutations in lung cancer that the clinician can use off-label. So we can pick up these very isolated or unusual mutations and possibly have a targeted therapy for them. For drug development, there's been expedited and extended approval of drugs, and how it affects us is that sometimes we have to have a particular companion test when we're actually reporting those out. So paying attention to the companion test, when it gets dropped, which clone, all of that may be something that's relevant in your lab, and you may have to do additional validation studies if you're not using the particular clone. And then biomarkers, we have this, or at least the clinicians, I know probably you realize this, but the clinicians think that every biomarker is the same in every tumor. So I can just take a HER2 and put it on gallbladder cancer and you guys can give me a result. Well, we know, especially with HER2, this is the perfect one. The scoring system and the grading system is completely different in breast and gastroesophageal adenocarcinomas. And we think it's probably different in colon too, but we don't have a lot of guidance on that. KRAS mutations are rare in anal squamous carcinoma, so you would think you could use some anti-EGFR therapy in there, but it really leads to unacceptable toxicity in those patients. BRAF mutations are seen in sporadic MSI-high tumors and colorectal cancer, but not in other sites. So you can't use that as a test to say that this is sporadic. And then things like positivity for PD-L1, we interpret it differently on the site, whether you give a CPS, a TPS, or minimal positive value. And even on the tumor type, that minimal positive value is different for even 2 different tumors in the esophagus. So which tests are needed specifically for colorectal patient care and why? So this is the recent colorectal guidelines that just came out in September for colon cancer. And really, we don't have a lot of new things in here. You can see DNA mismatch repair system, the RAS-RAF mutations, but some of the new things are the HER2 amplification, tumor mutation burden, and the fusions. There are some additional studies that they allow for extended sequencing for actionable items, as we spoke of before, and clinical trials. So the actionable items in colorectal cancer, again, I kind of feel like compared to lung, we're a little lagging behind, and I wish we would get more therapies, but hopefully we're getting there. Right now, the big thing for colorectal cancer is the immunotherapy, which can be used for tumors that are MSI high or have high tumor mutation burdens. There's been a lot of studies now that have confirmed that if you have a KRAS or NRAS mutation, that you're not going to respond to anti-EGFR therapy, and that's kind of solidified that for the clinicians, with a couple of exceptions. BRAF positive tumors also were not responding to anti-EGFR therapy, but they can also, in certain patients, add a BRAF targeted therapy now. So combination therapies are coming along. And then HER2 overexpression or amplification. We really want amplification, not just overexpression without the amplification. So we have to make sure that that is correlating. We can use anti-HER2 therapy, but it is a combination of actually two drugs. And then NTRK fusions and RET fusions are extremely rare in colorectal cancer, but when you get it, when you have one, we have an inhibitor for that. So certainly that can help with the patient. And just to let you know, we have a few clinicians who order PD-L1, but it's really not indicated in colorectal cancer. There's no decision-making based on PD-L1 in colorectal cancer for immunotherapy. So when in colorectal cancer should you be doing this? Again, it's a conversation with your clinicians. I'm at an academic institution. We're able to have, because we work in subspecialized group, we have a nice conversation with our, we know all of our oncologists, so we can have that conversation with them and explain why we would rather wait. And it also may affect patient billing if we're doing something that's not approved, especially when guidelines like NCCN come out and say, hey, you're not supposed to do this test until you're getting a metastasis. So that conversation with your clinicians might be helpful. And so right now, and according to the NCCN guidelines, the only thing that they really need at the time of diagnosis is the DNA mismatch repair evaluation. I do know other academic institutions that do the whole NGS panel on the first diagnosis of colorectal cancer. That's not our particular practice, but it might be a practice that works for you guys. And then all of the others, like I said, for advanced or possibly recurrent disease. So a lot of times they will have to try the first-line cytotoxic therapy before they try any of these targeted therapies. So let's talk about some of the particular alterations and how we can treat them. So the immune microenvironment is kind of utilized in or seen as a very important thing, especially in patients who have DNA mismatch repair system deficiency, when they have a high tumor mutation burden, and often that goes along with some type of DNA repair system. It might be mismatch, it might be polymerase. And then there is another test called immunoscore, which correlates with a lot of these disease processes. So when we have repair deficiencies in our DNA repair, it doesn't have to be just mismatch. It could be in the, as I said, in DNA polymerase. So pol E, polymerase E, polymerase D. What happens is you're not able to repair your DNA, and when you can't repair your DNA, you get a high mutation burden because you have tons of mutated proteins. Those mutated proteins end up being expressed on the cell surface. that attracts inflammatory cells, and then immunotherapy can actually then take the brakes off of the inflammation and have it even attack the tumor more. So this is kind of just a cartoon of how that happens. We can see the mutated DNA in the cell. It kind of breaks out, it's not doing anything, the cell, and this is my simplistic view of it, the cell kind of kicks it out to the cell surface, and then, or the cell is dying and it gets out into the microenvironment. APC cells, dendritic cells pick it up, or it gets presented on MHC receptors and presented to T cells. And if the T cell's activated, it can then destroy the tumor cell. So in colorectal cancer, one of the indications for immunotherapy is having a deficient DNA mismatch repair system. Certainly now, for a number of reasons, there has now been kind of acceptance of doing universal MSI screening for colorectal cancer. It's now recommended by all of the major guidance organizations, as you can see here, including ASCP. It started out as being more of a Lynch syndrome screening, but and now it's kind of morphed into a whole bunch of other things and very, very important for treatment. It can also be used for diagnosis when you have a odd-looking, poorly differentiated histology or with atypical features. Sometimes I think, maybe this could be an MSI high tumor. I do the stains. If it is, it helps me then makes me feel better that this isn't something else and I don't have to go searching for another tumor type. It can also be, of course, prognostic. One other thing. Just remember with these tumors too, they don't stain like normal colorectal cancers. They can switch their phenotype from cytokeratin to a cytokeratin 7, positivity, negativity for CDX2 and cytokeratin 20. So that can be a pitfall unless you recognize, oh, maybe this has DNA mismatch repair deficiency. It certainly is prognostic. We know just without treatment alone, these patients have a better prognosis, probably because they attract inflammatory cells. And you can see stage 2 tumors has about 22% of them at stage 2, but as you get to stage 3, it's even less, and it's extremely rare in stage 4 tumors, 3.5% of colorectal cancers. And the recurrent rate is actually lower too. So you can see recurrence rate of 11% versus 26%, depending on the proficiency of the mismatch repair system. And then it can be the most important thing, I think right now for the clinicians at least, is that it's predictive for treatment. It's predictive, one, for lack of treatment to 5-FU, which is the common adjuvant chemotherapy. It actually can be detrimental to patients who get this, so they steer away from this if they feel like the patient needs to have adjuvant chemotherapy after surgery. They will use a different chemotherapy if they're going to use something. It can be predictive of certainly of immunotherapy response, and it also provides the option of immunotherapy as first line. This is probably the only drug that will be used as first line in non-metastatic disease besides the typical cytotoxic drugs. And then it also may discourage adjuvant therapy in low-risk stage 2 disease. Stage 2 disease is our problem child. It doesn't have lymph node metastases. The clinicians are kind of on a quandary. Do I give them chemotherapy after their surgery or not? They usually use risk factors. This may be one factor where they might say, oh, it's an MSI high tumor. I don't think you need chemotherapy. So the mismatch repair system, I'm sure everyone has kind of seen a variation of this slide. It basically repairs the replication errors in daughter strands during replication. And it usually happens in these areas of repeating nucleotides, so which are called microsatellites. So basically, it's the areas of the DNA where they just have repeating nucleotides like T, 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 or it could be dinucleotides AT, 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 AT. And we'll kind of talk about why those have problems and why they have to be repaired a lot. So it results when you don't have a proficient system, it results in widespread instability, what they call instability, the wrong lengths of these microsatellites, and that's called microsatellite instability. So the enzyme that corrects this has two different heterodimers, and they kind of pair together, the MLH1 with the PMS2, MSH2 with MSH6. So if MLH1 is not expressed, usually the PMS2 is degraded, so it's not expressed either. So those two kind of go together. And we now know these charts of, whether or not this is going to be it helps us to determine whether or not it's going to be sporadic or likely Lynch syndrome. The only one that most of us think about as possibly being sporadic is the MLH1 PMS2 loss. However, that is not, in medicine, we never say never. You can have sporadic loss of MSH2 and MSH6. So just watch your wording when you're reporting some of these things out. So again, this is my simplistic view of how this works. It certainly can work when the DNA polymerase makes a mistake, but the reason why it makes a lot of mistakes on these repeating nucleotides is because it kind of falls off, and it gets on and it falls off, and then sometimes it gets back on in the wrong place because it doesn't really kind of know, and I'm totally anthropomorphizing the DNA polymerase, but it helps me to remember it gets back on the wrong T, and then it causes a problem, and now instead of putting 4 T's here, put 3 T's here, and now this daughter strand has 3 T's. And if that's in an encoding region or, maybe even a non-encoding region, that might be detrimental for the gene production translation, it can be a problem. So a proficient DNA mismatch repair system will fix these errors. So tumors that are commonly MSI high tumors are more commonly seen in the right colon. For some reason, we're starting to know a little bit more about the right colon versus left colon, why embryology would have a difference, but those tumors seem to be different. It seems, of course, in younger patients, especially when it's associated with Lynch syndrome. And they tend to make bulky tumors without lymph node, or with fewer lymph node metastases than you would expect. So a huge 9-centimeter mass and no lymph node metastases starts to get me thinking that it's probably an MSI high tumor. Some of them do have distinct histology, the medullary, the ones that have tumor-associated mononuclear inflammatory cells, which can be intratumoral, peritumoral, Crohn's-like. And then one of the other ones that's very specific is when I see a variegated histology, meaning that I see tumor that has 4 or 5 different morphologies in one slice of the tumor. So I might see mucinous, I see conventional, I see signet ring cell, I see medullary. I'm like, this is an MSI high tumor. Mucinous tumors can be MSI high or stable, signet ring cell the same. Neutrophil-rich inflammatory response also should trigger you. This might be an MSI high tumor. And then the serrated and adenoma-like colon cancers have a higher percentage than is typical in the conventional. Just remember that some of these patterns also can be associated with other mutations in DNA repair, which are much less common than the DNA mismatch repair system problems. And this is just kind of a picture to show you the mucinous on the top. In the center, we have the signet ring cell, the medullary on the other side, and then the tumor-infiltrating lymphocytes. And you can imagine if you're choosing this tumor for NGS, that's going to be a tumor cellularity of probably 10%, even though you probably do have a lot of tumor cells, you have a lot of inflammatory cells there. And then variegated histology, you can see where you have some conventional, some mucinous in the middle, some medullary over on the side, and then the Crohn's-like reaction. So how do we test for this? A lot of us use the immunohistochemical stains, and that's perfectly fine. Just remember this is an expression stain, so you certainly can have a protein that is expressed but not functional. And the analysis of microsatellite instability, which tests the function of these genes, can be looked at either by next-generation sequencing or PCR. Microsatellite instability by PCR has been kind of the workhorse for a long time. And then it helps for confirmation of Lynch syndrome. We can do some reflex testing, and then patients can undergo germline mutation evaluation. And if they don't find the gene, then the patients are deemed as Lynch-like syndrome. So this is what we should be seeing. We have the panel with the MLH1. I'm sorry, this should have been MLH1 and MSH2. Over on, I guess it would be the left, where you see the blue nuclei with the stroma and the lymphocytes around the tumor staining. So this is what I like to see. I like to see my normal my normal internal control right next to the tumor cells. I don't even look at the normal mucosa most of the time. This is the control I'm looking for. And then you can see on the other panel that both of them are expressed. Not every nucleus is going to stain. People ask me all the time how much of a percentage you need. You just have to tell, each slide is different. You have to look at the background and see how it's staining. So it's really easy, it's relatively cheap, and it's very sensitive and specific. You can get a lot of pitfalls, though, in DNA mismatch repair. I won't go through every one of them, but you can have false negatives, which would be that looks like you have expression or apparent expression, but you don't. Again, that expression of a defective gene can happen. Interpretation of intraepithelial lymphocytes, which is very difficult sometimes to determine. High cytoplasmic staining, you have to watch that. And then this nucleolar or granular staining, I'll show you in a minute, can actually go either way. It can be a false negative or a false positive. So I always take a look at higher power around when I think something is lost to make sure I'm not seeing nucleolar staining. And then heterogeneous staining can also go either way. It really depends on if you can tell if it's a fixation artifact or if you actually have a true clone that's not staining, because we do develop clones with microsatellite instability. So this is that nucleolar staining. You can see the little dots in the nuclei. Just be careful interpreting that. This is why I like to do a 4-panel stain, because I like to see the PMS2, see what's going on with it. If my PMS2 is expressed, then this is probably expressed. If it's not, then I have to decide whether or not it's an MLH1 loss with PMS2, secondary PMS2 loss. I have to decide then if I want to do MLH1 methylation promoter methylation studies and BRAF, or if it's a PMS2 issue, and I have to put that in the comment and communicate that to the clinician. So again, on this this panel, I don't think my pointers, let me get my laser pointer maybe. This would be the panel that I would feel most comfortable with interpreting. You can see the nice normal control in the background and the negativity in the tumor cells. This has some heterogeneity, but I think it's overall intact, and you can see that in the staining pattern here. This is completely negative, which you need to repeat this because we don't have the control staining in the background. Or there's another thing that could happen is there are patients who lose both of their DNA or have mutations in both of their DNA mismatch repair protein. They're born with that. So it's a germline biallelic loss of one of the proteins. Mostly it's in MSH6 and PMS2 because MLH1 and MSH2 are really needed, I guess, for life. So we usually see it in those two markers. The interesting thing is that their normal will be negative too because they don't have a normal protein. And then high cytoplasmic staining. Those are very rare though, and we'll chat about them in a minute. So radiation, it used to say treatment effect, but some other studies have shown this is mostly due to radiation. MSH6 needs to be in the certain cell cycle to be expressed, so you can see the decrease in expression. go back and get the pretreatment biopsy if you're having problems with it. And then fixation artifact, you can see that there's just a rim around here where in the middle everything is negative, so I would not interpret it. And then the bottom, I don't know, I might feel comfortable doing this. And then there can be odd combination markers. It's not uncommon to see some decreased or MSH6 loss with MLH1 and PMS2 loss. Most of the time it's decreased. Those have been shown to be associated with just widespread dysregulation of DNA repair. There have been case reports of a null phenotype, and the patient ended up having a germline mutation, but then also had somatic methylation of the MLH1 gene that turned it off. And then sometimes we see MLH, not uncommonly, MSH2 loss with just focal weak MSH6 staining. That's probably true loss of MSH2. And then what can you do? So I think starting with the 4-marker panel is important. Review your discrepancies. If you happen to notice there's a discrepancy between your IHC and your MSI analysis or your NGS, take a look at it. A lot of time it's operator error. And we don't want to put them in a Lynch-like syndrome basket if we don't have to. And then, repeat. You can do extended incubation. You can choose a different block. You can use a different specimen. And then remember, if you have a young patient who looks like FAP and you don't see any staining, it might not be your lab. They may have constitutional mismatch repair deficiency. Usually those patients are going to be young. They'll have a polyposis syndrome. Might even have cafe au lait spots. So just keep that in mind. And then you can always recommend additional workup if you don't feel comfortable with the stains. Tell them they really need to do some further studies, and that's okay. If you do have this, I've had this case before, and I really kind of kicked myself for not doing it. I thought to myself, this is an MSI high tumor by histology. The patient was 32 years old, and I was like, well, all the proteins are expressed. Guess it's not. And then luckily, the clinician was smarter than me and ordered the PCR, and it was an MSI high tumor. So this patient did have Lynch syndrome, which would have affected him and his family. So I won't spend a lot of time on the particulars of MSI testing by PCR NGS, just to know that there are different panels. Anytime we have differences in testing, we can have differences in sensitivity and specificity. It is pretty specific and sensitive it is pretty specific and it's sensitive, but you can see the sensitivity drops depending on which gene is altered. And then false negatives would be inadequate tumoral DNA because you're just looking at the normal DNA, or the MSH6 mutations, which you can see it's less sensitive in. And this is kind of what we see. We have, we compare, or some of them will require a comparison of normal to tumor, and then the normal, this is an electrophoredogram of these pieces of DNA. You can see this pattern here, and then in the tumor, you have more peaks, and it's shifted over to the side. So that would be a microsatellite focus that's atypical. Again, the sensitivity, specificity is kind of all over the place, and it's really going to be depending on the panel. If you're doing dual testing and you're catching some of those errors, the gene, as we saw before, and then sometimes the tumor type. Some tumor types that don't replicate very fast. Colorectal cancer is usually not a problem, but things like mesothelioma that don't replicate very fast can actually have loss of the DNA mismatch repair proteins. Those patients have Lynch syndrome, and the MSI analysis can be a microsatellite stable tumor. Just because it's not going through the cell cycles to cause that much DNA abnormalities. And then NGS is coming on. I'm sure you've all seen it in your biomarker panels. It's included, and it does basically kind of the same thing as the PCR, but instead of looking at 5 to 7 markers, now you're looking at thousands of microsatellites. It does require a computational algorithm to determine microsatellite instability, and those also come with their own issues, so more sensitivity, more specificity, depending on the one you're using. And it does have a good correlation with IHC and MSI, but as we're doing it more and more, we do see some divergence. So we're looking into some of those. As I said before, you know, you're either going to be, we know that about 15 to 20% of colorectal cancer has or is MSI high. About the majority of them are going to be sporadic. A much lesser amount is going to fall into the Lynch or Lynch-like syndrome. Lynch syndrome is when we can actually confirm that there's actually germline mutation. Then we have that very rare biallelic germline defect that can happen. And then Lynch-like syndrome can be a number of things. Maybe we just read the test wrong. Maybe it's hidden Lynch. There are likely genes and other things that can cause Lynch syndrome that we haven't figured out yet. And then some other mutations, DNA repair mutations like MUT-YH can also, because they just have so many DNA mutations that your likelihood of getting a hit in like both of your MSH2 genes is just higher. So the next thing we would do then is look for epigenetic alterations, which would be transcriptional silencing of the MLH1 gene. So we test for that by the MLH1 gene promoter methylation studies, and then often they have BRAF mutations in most of them. You can do one or the other, both at the same time, one after the other. And just some caveats, again, there's always caveats. You know, rarely MLH1 genetic mutations can have acquired MLH1 promoter methylation as a second hit. That would put you down thinking that it's because the methylation will be positive. You'll just say, oh, well, this is a sporadic. Rarely there are these patients who have germline constitutional epimutations that can silence MLH1, so that would be one of your hidden Lynches. And in some studies, they think it's up to 3% of Lynch syndrome. We can talk about that later. And then there are these secondary genetic processes I spoke of, like MUT-YH. And then about 1% of Lynch syndrome patients, though, can have a BRAF mutation. So again, we never say never. This is what the MLH1 promoter methylation assay looks like. We have a negative control and a positive control, and if the tumor has both, then it's methylated. And then you certainly can use the V600E BRAF mutation immunohistochemistry. We don't particularly use it because we were having problems with different platforms giving us different results. So most of the time, we just order the BRAF mutation analysis. Just remember, occasionally, BRAF V600E is the most common mutation in 90-something%, but you can have other mutations in exon 15 that this antibody might not pick up. So we kind of all know this about that it's the most common hereditary syndrome. A lesser percent is going to be in, most of it's MLH1 and MSH2, lesser in PMS2 and MSH6. What we don't talk a lot about is EpCAM. EpCAM is upstream from MSH2, and when it has a mutation, it actually can affect the promoter region of MSH2, and that's why it's up there, but we don't do any stains for it. The nice thing is that we can do a comprehensive germline mutation analysis. When I first started, we'd have to try and figure out what gene was the problem and test individually for those genes. Now we can do, this is the panel that we use currently, it's 81 genes, and it tests for a lot of those other DNA repair systems. Talk a little bit about tumor mutation burden because really it's incorporated into our NGS panel so that we don't really have to do it as anything very much as pathologists. Just remember that high for immunotherapy is going to be greater than 10 mutations per megabase. And again, there's an immunotherapy approval for metastatic disease as second-line treatment. And then just to speak a little bit about immunotherapy, since it's all over the place and it's been a game changer for a lot of patients, the FDA puts out their approvals based on a lot of that it approved it based on either DNA mismatch repair deficiency or a high tumor mutation burden. But the NCCN guidelines actually says that the FDA says that you can use it as first line for unresectable or metastatic tumors, but that's only for one drug. And the NCCN guidelines have actually adopted that as first line therapy for non-metastatic disease in certain patients. And then just to kind of show you what immunotherapy does, it basically it takes out the blockade off of these things that are regulating the T cells and lets the T cell then kind of go after the tumor cells by different ways. And hopefully it will destroy the tumor cell, and that's where we are. Just a minute on Immunoscore, because I don't deal with it. I'm not sure if anybody in here does, but you may get a block, ask for them to get a block. Looks at basically the immune microenvironment around the tumor. It does have some nice correlations. Of course, a lot of the MSI high tumors are going to be positive. But again, it's another test that the clinicians may want to use when they're trying to decide about adjuvant therapy in stage 2 tumors. The NCCN guidelines, it says there's insufficient data to recommend it. And then we'll talk just a little bit about altered pathways. It's going to be some of the ones we know about already, but HER2 is kind of making an entrance, and I'll show you why. So this is a nice cartoon that was in this nice review paper on upcoming therapies for colorectal cancer from actually one of the authors was our former president of MD Anderson. It kind of just shows you like a lot of the markers we're used to seeing in colorectal cancer, the RAS-RAF markers or genes, PI3 kinase, P10, APC, beta-catenin, and very common. And then just see that when these are constitutively turned on, it's going to put the cell in cell cycle and make it proliferate and kind of make it immortal. Other things that we can target, so some of these are, up until now, the genes were not targetable by certain drugs. And what we could target, though, was the receptors. So if we could block the receptor, getting its ligand and turning on the system, that was great. That helped. And the one we focused on mostly was EGFR. But HER2 now is coming into the picture as if that one is overexpressed on the cell surface, maybe we need to block that one, too. So KRAS is seen in a lot of tumors, 30 to 40% of colorectal cancers, and most of the time it's a single substitution, nucleotide substitution, so it's a missense substitution. And when you're evaluating for KRAS mutations, you really want to look through the whole spectrum of exons 2, 3, and 4. It's really important because it's really predictive to anti-EGFR therapy response. So what the drug does is it's an antibody and it blocks the ligand from binding. If you already have a KRAS or an NRAS or even a BRAF mutation here that's turning on this pathway anyway, when the ligand's not binding, this drug's not going to do anything for that patient. So, and it does have some prognostic marker significance, but it's not really used that much. There is an exception. There is now a new drug for this particular mutation, the G12C mutation, that can be used with anti-EGFR therapy. I think it's the only one that can be used for KRAS mutations in colorectal cancer. They thought that G13D was more likely to respond to these anti-EGFR inhibitors, but that has now been proven by this, my favorite study in the whole world, the ice cream study. The first studies that looked at this were the Crystal and Opus studies that showed increased survival in the patients who did not have the KRAS mutation. And then NRAS has come along too, where they suspected it was probably the same case, but now the studies, the results from the PRIME and the FIRE3 studies have shown that it is predictive. It is lack of response to EGFR inhibitors when you have a mutant KRAS. And then BRAF mutations, very similarly, again, we can do them by NGS or IHC. It does have prognostic features for microsatellite. It's a poor prognosis in a particular subtype, the microsatellite stable tumors. It is predictive for anti-EGFR therapy. However, we do have a BRAF inhibitor therapy that we can add to it and use. You can use it for diagnosis for sporadic MSI-high tumors. But again, that association is not seen at other sites. And then HER2, we don't think of HER2 as in the family of EGFR, but EGFR is HER1. So it can pair up with HER2, so the more receptors are there, the possibility more ligands can bind, possibility the cell cycle or these cell activators can join. So it's in a very small amount of colorectal cancer. It's probably less than 4%. They also can have mutations too, but we're not worried about mutations right now. We're worried about overexpression and amplification. And then as I said, very small amount. It's only used in RAS. It's only needed to be tested, actually, when you have a RAS-RAF mutant. Now, a lot of times they'll order all of these tests at once, but it's only applicable to a patient who is not going to have constitutively active RAS-RAF pathway. Again, it's predictive because you can't use the anti-EGFR therapy, and we do have the targeted therapy, which is a combination of two HER2 inhibitors. And then the big thing with HER2 is that we don't have recommendations from the pathology societies to know how we're supposed to test for that. So it's kind of the Wild West. People are doing everything from just description to using breast marker scoring to using gastroesophageal to using some other specific markers. And just to show you that this is a HER2 3+ in colorectal cancer, usually when it's positive like this. Very rarely do I have a 2+, and I send it for, we reflex fish on 2+, that it comes back as positive. The NCCN guidelines did come out and recommend the Heracles criteria, which was tested on colorectal cancer, and you can see it's very strict. It has to be 3+ and over 50%. If it's less than that, you still have to reflex it to fish. So whatever you guys think you're going to use and what you can communicate to your clinicians, that's fine. But I do recommend reporting the system that you use. Just briefly, and we're kind of almost finished, alterations in key pathways, these fusions for INTRAC and MET, they're both very similar. They're extremely rare in colorectal cancer, less than 1% for both of them. They're often seen in wild-type KRAS and RAS-BRAF tumors, and most of them are associated with deficiency and mismatch repair. So likelihood this patient's probably going to get immunotherapy, but they do have a targeted therapy for both of these tumors. So very similar in both that they could use. Circulating tumor cell DNA is certainly coming up. Just to know, we don't really have any role in when the clinicians order it. Some people do use it as a liquid biopsy instead of getting a tissue biopsy. The sensitivity is much lower in that setting for them to actually find clinically relevant mutations. So that might be something you might have to have a conversation with your clinician. And the NCCN is actually very cautious on this because as a diagnostic tool, maybe surveillance might be coming. And then there are these multi-gene assays that the clinicians may order. So going to the end, future directions. Again, we have some therapies in these arenas, in these topics. A lot of them have been left, to still be under investigation, and we don't know. I mean, this can become quite complicated pretty fast. Some of the future directions I see is that they may be starting to allow first-line therapy or off-label use earlier than just having the patients go through the first round of cytotoxic therapy before deciding that. There should be clarifications on how to use these ancillary tests and when to use them. We know we are probably going to get to tumor site-specific standards. So gallbladder cancer may have its own scoring system for HER2. We don't know. There are going to be new techniques that come out. One of our pathologist, Dr. Krishnamurthy, has actually developed a confocal microscopy where she can identify the tumor just on fresh specimens. And she doesn't have to do an H&E. She knows exactly where the tumor is. That can be put in a block, and just the whole block can be sent over to molecular. So we don't even have to do an H&E on it. That's not in prime time right now, but that might be coming up. And then other things like developing matrices, artificial intelligence probably can see patterns better than we do. So putting all the things that we know about a tumor might be something that comes up. So I am right at time, but I'm happy to hang around and answer any questions or talk to anyone. So in our conclusions, we have biomarker and molecular testing is going to be continued to be incorporated into clinical care. It may even be more incorporated, like HemePath incorporates and Neuro incorporates now. We haven't gotten to that in the GI arena yet. There have to be nuanced approaches to biomarkers, and that's going to further evolve as we learn more about these markers. There are going to be numerous indications for testing GI tumors, and most of them are going to relate to targeted therapy. And then we may be able to, use targeted therapy as significant drivers for molecular market testing. As these indications for the certain drugs are expanded, the types of indications, the standards, the thresholds are all going to have to be reconsidered. And I think that's all I have. Thank you so much for your attention.